What bunions are is a deviation of the first metatarsal, which is the bone that goes to your big toe, and it causes a bump on the inside of your foot, right at the big toe. They tend to be more common, as I said, in women than in men, and that reflects partly shoe wear that women wear. It's a problem largely that I see in middle-aged women, but there's a subgroup of patients who are teenagers and so forth who have this problem as well. The issue is that the first metatarsal, which is the bone that goes from the middle of your foot to your big toe, is deviated out of position. There's an inheritance component to this, and it's exacerbated by shoe wear. And patients vary greatly in the intensity of the symptoms that they have from this problem. Meaning I can see patients who have a mild bunion that may be pretty uncomfortable, and I may see someone who's got a pretty big bump and an ugly looking foot that it's not too uncomfortable. It's certainly not mandatory at all that bunions need surgery. The reason to operate on bunions is basically that they've failed non-operative therapy. And what is non-operative therapy? It's wearing the appropriate types of shoes. It's sometimes an arch support can be helpful. Basically not squishing your foot into a shoe that it shouldn't be in. Now, we live in the real world, and I'm not going to ask a 45-year-old woman to wear space shoes. I mean, that would be absurd. So getting into a reasonably fitting shoe comfortably is the goal. So the question is, how do you correct a bunion, and what are the surgical principles involved? And the answer is that if you look at a normal foot, which is this model, you'll see that this bone and this bone are parallel. And so that's what you're trying to correct, because in a bunion, this first metatarsal is deviated that way. So the couple of x-rays that I'm going to show you there, you'll notice that on the left, there's a bunion that's a little milder, and on the right, there's a bunion that's more severe. So for me, the bunion on the left gets what I call a chevron-Aiken procedure. And the chevron-Aiken procedure is a procedure that's done under local. You're in and out the same day. And what I do is shave off the edge of the bone. I cut the bone, shift it over. In this particular procedure, I use a dissolvable pin, and then make another little cut just on the other side of the joint, called an Aiken procedure. And you can see from the post-op x-ray on the left that she's gotten a nice correction. That's a very appropriate procedure for a mild or moderate bunion. If you look at the other side, in addition to, she has a couple of hammer toes and so forth, which is a different discussion. But what I've done is I've gone to the base of the first metatarsal, which is the base of this bone. And you'll notice on the post-op x-ray that there's a metal plate there with some screws. And what I did is cut that bone more towards the base and made it parallel, that is the great toe, first metatarsal, parallel with the second metatarsal. In addition, I do some soft tissue balancing at the big toe, and that gets an excellent correction for a more severe bunion. Those two procedures correct, as I said, the vast majority of patients. I should also add that both procedures are done under local with some IV sedation. People don't like to be wide awake for this, but they like to be wide awake right after I'm done. The question is, what's the recovery like from bunion surgery? And of course, there's some variability between patients. But in general, it goes something like this. And I generally will put it in writing for patients and tell them this is what you can expect in terms of your recovery. If we're doing one foot, you'll be in and out the same day. We do it under local, meaning we have an anesthesiologist there who gives you some IV sedation so that you're in la-la land and you don't really care. And while you're taking a nap, I numb up the foot and proceed with the surgery. Your anesthesia is so light that you don't even need to go to the recovery room, and you go right back to the preoperative area where they'll give you some coffee and you're out within an hour or so. I like patients to go home. The patients go home and keep their leg elevated for 2 or 3 days. I always say to patients, keep your toes where your nose is. So in other words, your toes should be nice and high. For the initial 6 hours or so, there's not much pain at all. The next 24 to 36 is the period that patients have the most pain. In many patients, I will leave a a little catheter in that drips some Novocaine into the area that diminishes the pain. But that's the worst period for most patients, that 24 to 36 hours after surgery. At 2 days, I'll see the patients in the office and change their dressings. At a week, the following week, I should say, the patients come in and have their stitches removed. So that's at 9 days post-op. Some patients I'll allow to weight bear at 4 or 5 days. Some patients I'll ask them to stay off it for about 10 days to 14 days, depending on the particular type of surgery. Patients then wander around in a post-operative shoe, which is a black Velcro shoe, for about 4 or 5 weeks, depending on the procedure. And I usually tell patients you can get back on a stationary bike, as an example, at around 6 weeks or so, and running tennis is around 3 months, 12 weeks or so. And there's often some improvement for up to 6 months with this type of surgery.